Welcome to The Breakdown, the orthopedic podcast where we dig deep into the world of bones, joints, and everything orthopedics. I'm your host, Lauren, and today our topic is telemedicine unveiled. Should you take the leap? Telemedicine is also known as virtual visits or telehealth. We're going to discuss its impact on healthcare and how it's transforming patient care across the globe. Today, we have an exciting guest with us, the one, the only, Dr. Alex Vaccaro. Dr. Vaccaro is no stranger to the podcast, and he's no stranger to me. He's my husband, to be fully transparent. We've been married for 11 glorious years, and we have the pleasure of not only living together, but also working together on occasion. Alex is a world-renowned spine surgeon who's been practicing orthopedics, specifically spine, for over 30 years. He also serves as the president of Rothman Orthopaedics and the chairman of orthopedics at Thomas Jefferson University Hospital. His CV is as long as the Bible. He has over 900 peer-reviewed and 200 non-peer-reviewed publications. He's published over 372 book chapters and is the editor of over 63 textbooks. Alex, welcome to the show. I'm exhausted.
By the way, I miss you. I'm away from you, and every second I'm away from you, I get depressed. So it's just great to see you. Can this be a 12-hour podcast? Is that possible?
All right. Well, we're so glad to have you. And the reason why I asked you to be our guest today is because I know that you incorporate telemedicine into your practice weekly. When and why did you decide to start conducting telemedicine visits?
So we got involved in a company, and I don't remember the exact name, but they wanted to look at the feasibility of doing telemedicine, and none of us knew anything about it. This was before COVID. So we did studies at the Rothman Institute and Thomas Jefferson University where we sat down and we said, okay, listen, if someone is doing well after surgery, it's an inconvenience for them to drive into the city, inconvenience for them to leave their work. If they can just get x-rays taken in an outside facility, then I could talk to them on the phone, talk about their symptoms, look at their x-rays, because x-rays are stored on a imaging archive system. It'll be so easy for the patient, save them a tremendous amount of time. Because remember, driving into the city, 45 minutes. This sounds like a credit card commercial. Driving into the city, 45 minutes.
Yep.
Parking, $30. Waiting in an office waiting room, an hour and a half. Having a visit with your physician, then getting back into the car, driving back home, missing a day from work. All that goes away with telemedicine. So we did feasibility studies to show it worked. And then we put it in the back and none of us used it. COVID hits, and literally in the center of Philadelphia, we can't take care of anybody. People can't come in. Now I'm a spine trauma surgeon. I'm a spine specialist. We have emergencies all the time. I need to communicate. So we revived telemedicine again, and it was a life-saving for the patients. Now patients had access. So from their home, they can call us, sit down, we can go over everything with them. And about 75% of all spinal problems can be done safely over telemedicine. Let me tell you what I mean by safely.
Yeah.
You're obviously not examining a patient because you're
Right.
using communication.
Well, that's a big part of an orthopedic exam is the physical touch. So that's the part where, how do you handle that?
Yeah. So what you do is you can actually go through, we validated physical examinations that a patient could do at home. For instance, they could take a filament and put a filament on their arms to get a sensory examination.
What's a filament? Explain what a
A
filament is.
a filament is like a bunch of light threads that you touch the skin. Can you feel it? You could take something sharper. Can you feel the
I see.
pinprick to do a sensory examination? You could do range of motion, but you'd be doing an exam. Range of motion. Do they have a palsy of a nerve? They can't lift their arm above their head. The deltoid muscle or the C5 nerve root doesn't work. They can do that. And then you could have them lift weights. Like, how strong are they? You can't do manual motor testing to see someone's strength, but you could have them do maneuvers. So if you need to do that, you can do that. You can do also a lot over audio. I mean, if someone has a big disc herniation on an MRI scan crushing a nerve on the left side, and you say, well, listen, where's your pain? My pain is in my left leg. It goes down to the foot. Well, that's where that nerve goes, down to the foot. So now you've done it. Okay, now I want you to lift your foot up and down like that. Oh, by the way, doctor, I can't. So you know automatically the person has a foot drop. So we can get that information. And it turns out today, 40 to 50% of the people I operate on, I meet for the first time in the operating theater.
So that's what I was going
And
to ask. So do you have a protocol of when it's appropriate to see a patient virtually versus in person, or basically anybody? Because like you said, you don't have to do that physical examination. So you can see a new patient. And so you were just saying the first time you meet them is in the operating room?
Yeah, so let me just clarify. There are certain protocols where you have to do it in person. If someone calls me up and says, I have symptoms consistent with a medical emergency, and I'm a spine surgeon, so let's focus on the red flags of spine.
Yeah.
I have fever, chills, night sweats, night pain. They may have a tumor infection. I have perineal, which means in your groin numbness. I have a difficult time initiating urination. They're going right to the emergency room,
Yeah.
and you're examining them then. If it's a deformity patient, it's very difficult to evaluate a deformity patient because you could look at an MRI scan of their lumbar spine and they could have severe pressure on their nerves. And then you say to them, well, when you walk, are you bent over when you walk? I want to visualize what they look like because one of the goals of scoliosis surgery is to balance the person. I'm going to make that person come in. I can get a tremendous amount of information from telemedicine. And by the way, you and I are communicating in a very relaxed manner.
Yeah.
Telemedicine is easy to communicate. I'm in Colorado right now.
Yeah.
I did office hours by telemedicine. I spoke to a woman for an hour who told me that the deepest concerns about her body and stuff like I
Wow.
wouldn't have the time. In an office hour, when you have 50 people and noise everywhere and people are running around, I just hung
Yeah,
out and
it's
just
a
talked to
much
the
more
woman.
relaxed setting. It's more intimate. You know, you kind of feel you're in the comfort of your own home or your own space. And so what percentage of your patients are are treated virtually,
Well, I
would you
do office
say?
hours twice a week. I do office hours twice a week. So, and I'm an academic professor. So, as part of my job, I have to teach. So, a lot of Fridays, today's a Friday. I'm at a spine meeting in Vail, Colorado right now. So, I did office hours today. So, you don't take days off anymore when you go
Yeah,
to meetings.
right.
And
Well,
then if you're
that's even with
traveling,
the school kids, no more snow days. You can you gotta sign in virtually. But go
that's
ahead.
not good for you, and it's not good for me with our kids. So, no, but I agree with you. So you're always in touch. So I
Yeah,
think it's improved care. So what we have to do is we have to always petition Congress to continue to allow audio audio and visual telemedicine. Because let me just explain the rules to you.
yes,
Before COVID, you couldn't do telemedicine. And if you did telemedicine through CMS, which is Medicare, Medicaid,
right.
you would have to leave your house and go to a sanctioned facility, just like you and I are doing a podcast, and do it there. The
You as
problems,
the physician, so you had to
no,
be in a
the
medical
patient, the, no, the
Oh,
patient had to go. And why? Well, listen, what does telemedicine allow? It's great patient care, but it allows unfettered, unlimited access, and
right,
that increases the cost of care.
right.
So we're studying it ever since it increased. If anyone could do a telemedicine, so Congress made it more difficult. You had to go to a special sanctioned place. Now they got rid of that for COVID, and now they're trying to bring it back. Also, I have people around the world calling in for telemedicine. If you don't have a license in the state of Montana, I can't do a telemedicine with you. So Congress is looking at that, saying a Pennsylvania license may be applicable for telemedicine in other states. So remember, you have to do it by your license, what states you're allowed to be in.
Right.
Now, outside. So I see people from all around the world telemedicine, but I can't do telemedicines with people in certain states in America because I don't have a medical license.
Right. So I do want to point that out for the listeners that if you are trying to schedule a virtual visit, you have to check in with your insurance. And even if you call Rothman, our team, our access team, our billing team, they'll be able to walk you through what you can and can't do as far as visits with your insurance plan. And so each state has their own protocol, each insurance plan has their own protocol. So you just have to make sure that you're checking out to make sure that you are covered. So, like you said, if you're not licensed in a certain state and that's where that patient lives, then you may not be able to treat that patient.
Unless your state medical board has an agreement with that state. Now, I
Right.
think there's 38 states that have a consortium. Now, I have a medical license in 6 states. So those are the 6 states I do telemedicine in
Right.
all the time,
And I
which is
think
great.
that's important for the listeners to know that, they may just assume that because we have offices in Pennsylvania and New Jersey and Florida, that those are the only states that our physicians are licensed in, but that's not the case. So which states are you licensed in?
New Jersey, New York, Pennsylvania, Delaware, Florida, California, And of course, Hawaii, because everyone needs a medical
You're
license in
treating in
Hawaii.
Hawaii every week.
We need a medical license in
Oh my
Hawaii.
gosh. But I do just want to I want to read this study. In 2021, a study published in the Journal of American Academy of Orthopedic Surgeons, AAOS, found that 64% of orthopedic surgeons had used telemedicine in some capacity during COVID-19, where prior to COVID, only 2% of orthopedic surgeons were utilizing telemedicine. And that was 2021, where it was 64%. So now it's probably even higher. So I feel like
And I'll give you an example. As I'm speaking to you now,
mhm.
I received a text that a woman was admitted to a hospital in our area
Uh-oh.
getting paralyzed.
Oh, geez.
So I'm going to do a telemedicine with her today. The
Yeah.
second they the second they get the imaging studies, I'm going to do a telemedicine. I'm going to see the studies. I'm going to verbally try to understand her neurologic exam the best I can. And again, it is not as complicated. The subtleties are absolutely right. And remember, when we see people the day of surgery, we do a formal examination at that point. At that point, we do a formal examination. And there have been cases where I've decided not to proceed with surgery because of the findings of my examination at that time. But that I would say that's less than 5%,
Right.
95%. And patients, I have not had one patient, and I've been doing it since COVID, ever complain to me, and they love it. You
I
you
was
can't
gonna
imagine.
say, do your patient satisfaction scores differ from your in-person visits versus your online telemedicine visits?
I never check, number one, because why would I ever do that? But number
Well, I'm
two,
sure you would hear
I,
about
I
it.
get
So just to
I
put
hear
it
about
out
it.
there,
So
we take patient satisfaction very seriously at Rothman. So if there was an issue, you would know about it. So the fact that you don't know any issues is a good thing. But go
right,
ahead.
and let me bring up one other point. When our child gets injured, I take him to a hospital. I'm a physician. I walk and I sit in that emergency room for 6 to 7 hours.
Yeah.
I'm just like, oh my God, this is taking, and we all have things to do. You have removed that factor through telemedicine. No longer is there a wait. The way we set it up is the second we're ready for the telemedicine, we notify the patient. So you have a patient at work, doing work, you get a text. Can you get on the phone in 5 minutes? Sure. Let me tell my boss I'm going to do my appointment for the next 20 minutes rather than leaving for the entire day.
Right.
So it's works
Yeah.
out great.
So let's talk from the provider side for a minute. What advice would you give to a provider, even some of our own physicians here at Rothman that aren't utilizing telemedicine? How, you obviously recommend it. Why aren't all Rothman physicians? I mean, we
Well,
have a good
number
amount that
one,
do, but not all do it. Do you think it's just the
it's like,
fear?
well, I'm going to give an example. At my age, every time my daughter or son comes back with a new app or new electronics, that's not happening. I'm never using it. Don't even show it to me. It's
Yeah.
until you begin to use something, you realize, oh
Yep.
wow, I guess the telephone was a useful invention. You're like that's it makes sense. So you have to understand how to work it into your workflow. So when you begin office hours in the morning, and we begin ours at 7:30, there's always a lag. People are parking, people can't get in, the valet
Right.
service. I do 5 telemedicines right away as everyone becomes situated,
Yeah.
and then during lulls and when the staff is on a lunch break, I'll do telemedicine. I work it into my workflow. Today, telemedicine all day today, and I'm dictating all those notes right now. So
Yeah.
it works out great. You're never away from taking care of patients.
And there's such a cost savings to it because you figure you don't need office space. Like you're saving all of that office space. Even staff, you don't have to worry about having a front desk person that day. You can make room for other physicians to see patients in the office that may need to for post-op and things like that, or, anything that does require an in-office visit. Um, what are some of the concerns or some of the challenges that you faced where it seems like you have it down to a science now, but I'm sure it wasn't that
Let,
easy in the
so
beginning.
let's break it down to the challenges. Number one, who pays for it?
Yeah.
Is some of the insurance companies are not into it. Some of the insurance companies, when I started, I would have someone who couldn't use their arm. They were miserable. They were getting paralyzed. It was static. It wasn't a progressive neurologic deficit because if it was progressive, we do it right away. But they said for the last month, I can't sleep. I can't use my deltoid. I can't raise my arm. Boom, sign them up. I'll do you tomorrow. The insurance companies initially said, we're not going to approve that unless they do an inpatient office visit. That's just an insurance
Yep.
company unnecessary barrier and abuse. And I'm like, come on now. Now you have
Does
two
that happen
visits.
often? Where the
It doesn't
insurance
happen often.
Okay.
Doesn't happen because we fight it. It happened in the beginning, but we're like, come on, let's
Got
use
it.
common sense.
Yep.
So I'm going to go from everyone's perspective. So the insurance company looks at it for what it is. It could increase access, which means it could increase the cost of care. So what they need to do and we need to do is we need to study it to say, okay, when is it appropriate? When is it not appropriate? Because if it increases the cost of care, but doesn't move the needle in terms of outcomes, then it may not be appropriate. So we're
Right.
studying it. Most of the studies have come back, said thumbs up, it works out great. Now, in terms of payment, you have audio and you have audio and visual.
Right.
So, of course, you get paid to do more if you do the visual component of it. But a visual component of it, if you take grandma, like my mother, who said to me, I will never use the iPhone, get that away from me. I bought her an iPhone to get it away from me. I'm not using it. So she's not going to do
The visual part
visual
of it.
because
Yeah.
she doesn't even have a computer. She doesn't have a laptop. So it's in my it doesn't make any sense. So I do audio. Now, the insurance companies pay a lot less to the doctor for audio, which is okay for me because surgeons are doing telemedicine for one reason,
But let
to
me ask
figure out.
you, sorry, I didn't mean to cut you off, but you
But
said
that's
you do
okay. That's
audio.
okay.
How are you doing your physical exams? How are you seeing their range of
Oh, no, no,
motion?
I'm saying if I have to do that, we could do the visual.
I
I'm
see.
just
Got it.
there's
Got it.
audio and visual. So, but if a lot of the older people don't want to do visual,
Yeah.
they don't even know how to
Well,
do visual.
because so as I understand it at Rothman, we have an app. It's called the Helo app, and that's the typical way to log into your virtual visit, where an hour before your appointment, you get an email reminder. Don't forget, your appointment with Doctor So and So is happening at 9 a.m. And then 30 minutes before that appointment, you get a text with the link, and then you click on that link, and then you're placed into the waiting room, and you wait for the physician there. So I understand you don't utilize the app. You just
No, no.
prefer to call. So you
I'm
give
a
your
s
patients
I'm a
a
surgeon. Yeah. I'm a surgeon, and that's great. That's like an organized office visit, which I don't like. Everyone could if you like it, you could do it. I don't like that. I just spent an hour and a half with that patient. Now I have a follow-up with someone who just wants to know, do the X-rays look good? And I don't want to have that person waiting in a waiting room because that defeats the purpose of waiting. So, but it's good. So if
yeah,
I need to see the patient, I do that. If I need to do a visual exam, I do that. But if I don't, remember what I said in the very beginning, 75% of the time, a spine surgeon can make a diagnosis and institute treatment without doing an examination. That's just the reality. If you like
wow,
it or not, if you
wow,
like it or not, that's the reality. You have really bad arm pain that goes down to the middle finger. Well, guess what the middle finger is? It's C7. So if you have a disc herniation, it's C6, 7 in that MRI, which I'm looking at.
yeah.
I know where your
You know
pain's coming from.
exactly right, right.
Yeah. Now, sometimes I can't differentiate between a central disc herniation and a peripheral compressive neuropathy, such as carpal tunnel, cubital tunnel. Can't do it. Sometimes I can't differentiate between a peripheral polyneuropathy or a radiculopathy. And I listen, for people who love this podcast, we won't define those terms, but there's times when I need to. The diabetic can have sensory changes. So sometimes I have, and those people, I am asking them to come into the office. I've done the background but 75% of the time,
Yeah.
you do not need that. You do not need that.
It's amazing. So just the convenience, it's a win-win on both sides, for the patient, like you said, they don't have to travel into so for you, you see patients in Center City, Philadelphia only. You don't go out to the burbs or, so if somebody wants to see you, they have to travel into the city. They have to sit through the traffic, park, pay for parking. It's not cheap. Take the elevator up, it's a whole to do rather than just staying home by the fire in their PJs and logging
Right,
on to see you.
the magazines in the waiting room aren't that good. And I tell people because that's what I do when I go to doctor. It's all about if they
It's
don't
all
have that
about the good
highlight. Remember the highlight?
magazines.
It's all about the
Yeah.
magazines.
It's so funny. I used to be the one in charge of ordering the magazines for the waiting rooms. Isn't that crazy?
Remember
Oh
the
my
highlight
goodness.
magazines when we were younger? Highlight. It
Highlight.
was
We
called
still get them. The
highlight.
kids still get them. We've
Why
moved
don't I
on.
get
We've
them?
upgraded to the week. The week junior is
We have
what
to
we
bring
like
them
for
to
the
our
kids
house.
now.
Exactly. Okay.
So, okay. It sounds like so if you look at how far we've come from 2020 when COVID happened until now and what a seamless, process this has become. And even the insurance companies are getting on board. And I know I talked with Kelly Huber, our business office director, and they just instituted changes as far as coverage and everything for visits, for telemedicine visits. What do you think the future of telemedicine looks like in the field of orthopedics? specifically
It's
spine moving
well,
forward? Or do you
it's going
know
to
of
be.
anything that we don't know of yet? What can you
No,
share
no,
with
no.
us?
I'm working with companies that are just perfecting the examination, perfecting. I mean, right now it exists where you can do holographic exams where you can enter into a 3D virtual
Oh
space
my goodness.
and you're sitting across some patient and you put your little headset on. We have that already. So, but again, we have a lot of things in the operating room. I do robotic surgery,
Yeah,
and 60% of the time, I don't need a robot to do surgery with me. Precision, repetition of movement, lack of surgeon fatigue. So, do I
right.
have to immerse myself in a virtual room and talk to someone? No, but someone may want that from Saudi Arabia. Someone may want that from Dubai. Someone may
Yeah,
want that from Russia. And I'm like, whatever, I'll do it. It's not necessary. I tend to dumb things down to the simplest elements. Keep the cost down low, get the job done.
yeah.
You're miserable, you can't walk, you have spinal stenosis. I'll communicate. Let's get it done as quickly as possible.
Do you utilize any of like the iPhone features or anything like that to monitor like movement of a patient, how they're walking, anything like that? Or is
Glad you
that
brought that
yet to
up.
come?
I'm glad you brought that up. In 2009, we went out and patented using remote monitoring to use a gyro within an iPhone. iPhone can do anything.
Right.
It could even launch missiles. So it could do anything you want it to do.
No.
So we use the iPhone for all remote monitoring. When you glucose, blood pressure, heart
Right.
rate, it's a great tool. Now some of the functions are FDA approved, some are not. We like to use it to look at. We originally looked at it and did research on after you do spine surgery, if we notice that the person's cadence, distance, and travel was what we expected, we would get a green. If it was less than expected, we get a yellow. If it was red, that means the person's not moving. We would notify the patient. So that's and we use gamification where we would like I like to collect stamps. So every day I get a stamp of the day. I get a little and okay, thank you. We give that to the patient. He reads what they like. Oh, by the way, can you answer these three questions? From 0 to 10, what's your pain level?
Hmm.
What pain medications are you taking? Do you plan to get an injection? We like to get feedback. So we have
Yeah.
those technologies built in. I just want you to know it's like dieting. People are into it, then they're not into it. People
Yeah.
are into it, then they're not into it. So that's in the future. We haven't had mass adoption, but that's going to happen.
Yeah. Amazing. Well, thank you for being here, for giving us the time, for explaining how this works from your end, from the physician end, from the patient side. Anything else we should know? Anything that I didn't?
No, I just want to say that I'm very depressed that I'm not with you right now. And I wish we were doing this
Well, see,
podcast
there is a
together
benefit of in person still, you know? I mean, virtual is good for
for
so many
intimacy.
things, but
We can't do intimacy virtually. Absolutely. We got to be together.
well, thank you, Alex. We appreciate you being here today and for all of your insight and knowledge.
You guys have a good day and I'll talk to you later, hon. Okay.
All right. Alex, thank you so much for sharing your insights with us today. I think we all learned a lot and are more aware of how we can take advantage of virtual visits as an option for not only orthopedic care, but any type of medical care. For our listeners out there, if you're interested in learning more about telemedicine or want to explore whether it's a good fit for you, we definitely encourage you to talk to your doctor or message us, and we can certainly point you in the right direction. That's it for today. Be sure to stay tuned for more episodes and feel free to send in your questions. Until then, stay healthy, stay strong, and take charge of your health. I'm Lauren, and you've been listening to The Breakdown.